One of the main aims of sports cardiology is to really identify athletes who may have a cardiac disorder that could predispose to a sudden cardiac death. And we do this by cardiovascular screening. In some cases, we identify an athlete with a serious disorder, and that athlete may aspire to continue to train and compete. And in such cases, we provide tailored risk stratification to identify their risks and then give them an appropriate exercise prescription that allows them to perform safe exercise and therefore to accrue all the benefits of exercise on the cardiovascular system, but not to endanger themselves in any way. As things have gone on over the last 2 decades, of course, we're beginning to realize that sometimes people who exercise excessively, these are predisposed individuals, may develop rhythm disturbances such as atrial fibrillation or faults with the right ventricle. And in those types of conditions, of course, our job is really to try and advise those people how they could reduce their risk of atrial fibrillation or how we could even treat it. So sports cardiology really is is an evolving field that is really responsible for ensuring that people engage in exercise, including competitive sport, but do so in a safe and sound manner. People who exercise intensively for 4 hours or more undergo a constellation of structural and functional changes in the heart that allows the heart to pump very large volumes of blood around the body for a prolonged period. For example, when someone is sitting down, they're only pumping 5 liters of blood around the body, but when they're exercising intensively, this goes up to about 25 to 30 liters per minute. Now, in order to do this, of course, there's only 2 ways the heart can do this. It can either increase its rate and or increase its size. Now, the actual maximal heart rate that anyone can achieve is really governed by their age, and the general equation is that the maximal heart rate is 220 minus age, and very few individuals can exceed that heart rate. So the only way to increase cardiac output is to increase heart size, and in this respect, people who exercise intensively have about a 10% increase in the chamber size of the heart, that is the ventricles and the atria, and about a 10 to 20% increase in the thickness of the heart. The walls of the heart, that is. And these people can relax their hearts very efficiently, much more so than sedentary people, and they can contract their hearts much more vigorously, even at rapid heart rates. So it's really a combination of a bigger heart that can fill more efficiently and can contract more effectively during high heart rates. Generally speaking, the sort of things that kill athletes, this is what we worry about the most. That the first thing is that sudden death in sport is uncommon. It's rare. It affects about 1 in 50,000 athletes. But when it does occur, the actual causes are very dependent on the age of that individual. So in people aged under 35, the most common causes are genetic or congenital abnormalities that affect the heart muscle or the electrical tissue. If we look worldwide, then the cardiomyopathies, these are heart muscle diseases, are the commonest cause of sudden death, and examples include hypertrophic cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy. Certain electrical faults can also cause sudden death, such as long QT syndrome or catecholaminergic polymorphic ventricular tachycardia. Once an individual is over 35, then by far the most common cause of sudden death is atherosclerotic coronary artery disease, or blocked arteries due to furring up. So these are the sort of conditions that we worry about. But if you look at the general population, the sort of things that athletes usually complain of, they often complain of palpitation, which may be due to extra beats in the chest, which may have a serious reason or not. Some athletes often faint, and that may not be necessarily serious, but fainting in an athlete is relatively common because they have slow heart rates and a low blood pressure. And if they push themselves very hard and become dehydrated, sometimes these individuals can faint. And of course, we've got to be able to differentiate between a serious faint that may be due to a serious heart fault and a faint that can occur in young people. So we often deal with palpitation and faints in athletes. There are certain valve problems that are common in the general population, such as a bicuspid valve and a mitral valve prolapse, these types of valvular faults are present in 1 to 2% of the general population. And in many cases, we are often advising individuals who are diagnosed with these valvular problems who want to exercise regularly. Well, the sort of things that we assess when we're looking at looking for a cardiac problem, really, we have to take into account the age of the individual, the sex of the individual, the ethnicity of the individual, and the type of sport that the person may be engaging in, because all of these factors really play a very important role in how the heart adapts. For example, when we're looking at the most profound changes on the ECG or structural changes on the echocardiogram, then the most profound changes usually occur in adult male individuals who are engaging in endurance sports such as long distance running, long distance cycling, triathlon, rowing, canoeing. These are the sort of people that get the biggest hearts and the slowest hearts. So we've got to take that into account. And it's important to note that we rarely see this in adolescent individuals or in females. The other thing that we need to take into account is the ethnicity of the individual, because Black people, by this I mean individuals originating from Africa or the Afro-Caribbean area, often have marked repolarization changes on the ECG, which can sometimes simulate serious heart diseases or even simulate a heart attack. And one has to be aware of those changes when assessing these individuals. Clearly, once we've gone past that, then the sort of things that we look at when we're assessing cardiac structure is the thickness of the heart muscle, the exact size of the ventricles, because there is an upper limit beyond which clearly something cannot necessarily be attributed to cardiac adaptation. For example, a left ventricular wall thickness of more than 15 millimeters would definitely make me think of a condition called hypertrophic cardiomyopathy, or a left ventricular size of more than 7 centimeters in someone who's got an ejection fraction of less than 45% would definitely make me think of something like dilated cardiomyopathy. We often do exercise tests, of course, to look at the functional capacity of that individual, but that really depends on what we found in our preliminary investigations. One of the fundamental aspects of sports cardiology is to prevent sudden cardiac death. And we do this through screening. And these screening practices vary from country to country and from sport to sport. If we look at the United States, for example, the screening process is relatively basic and cheap, cheap certainly, and it involves taking a history pertaining to symptoms of heart disease such as chest pain, breathlessness that is disproportionate to the amount of exercise being performed, palpitation or dizziness, or even a family history of premature sudden death, because many of these conditions are genetic. And then there is a limited physical examination, listening for murmurs, checking for the blood pressure, or looking for something called the Marfan syndrome, which is a collagen disorder that can cause dilatation of the aorta and cause its dissection. In Europe, we also add in a 12-lead ECG, and clearly the European strategy is a bit better because we've added in a cardiac investigation. The ECG is very effective at picking up electrical faults of the heart, such as Wolff-Parkinson-White syndrome, long QT syndrome, and other repolarization changes that make us think of cardiomyopathy. Some sporting organizations that are financially well endowed, such as elite football, also add in an echocardiogram, which looks at cardiac structure and function. So these are the basic methods by which we try to screen young individuals. The difficulty really is in the older population. These are people aged 35 or more who are participating in mass endurance runs or triathlons that invite all comers. Really, how do you diagnose coronary artery disease? Because an ECG and an echocardiogram will not pick up a significant proportion of those with coronary artery disease. And the sort of tests that we've got available for that are relatively expensive, and they're not practical at mass level. For example, a CT coronary angiogram or a stress echocardiogram is not something that we can expose everyone to, because we just don't have those resources. So in those types of people, we have a relatively pragmatic approach, whereby if they are not exercising habitually and are relatively unfit and have either cardiac symptoms or risk factors for cardiac disease, such as diabetes, obesity, high blood pressure, and they wish to engage in vigorous or highly vigorous exercise, then we recommend that those types of people do undergo a thorough assessment with an ECG, echocardiogram, and an exercise stress test, or even maybe a CT coronary angiogram.